one question I want to ask you, because this is a very common discussion that I have with my patients. Let's say you have a patient newly diagnosed stage 4, you're just meeting them, you only have the fact that they have cancer, and you may have a PDL1 expression, and let's say it's like 90%. Can you talk to us about, is it okay to wait 3 weeks? You just mentioned that the molecular testing comes back 3 weeks. Why can't we start therapy now? Why do we need to wait? And is it okay to wait?
Yeah, so I think that's a tough question. I think a lot of it depends on the patient, how they're feeling, how symptomatic they are, how much tumor burden they have. We try to do rapid molecular testing whenever possible, in addition to the next generation sequencing testing, because we know that the NGS testing takes a longer period of time, 2 to 3 weeks. So the rapid testing is usually a week turnaround. And when we do the rapid testing, it includes EGFR, ALK, ROS1, and PDL1. So you should have that data, by the time you're seeing the patient or within days after seeing the patient, and that will be informative as far as what treatment you're going to offer. Anyone with adenocarcinoma histology, whether or not they're a smoker, I think, we know that, although rarer, EGFR mutations can occur in patients with smoking history. And if you see it, then you're going to go down a completely different path as far as treatment. And so I do think it's important to have that data. We know that the EGFR, ALK, ROS1 status is going to trump the PDL1 status. So patients who have an EGFR mutation and who have 100% PDL1, you're going to give that patient osimertinib and not immunotherapy. And in fact, we think that immunotherapy drugs don't work as well in our patients with EGFR and ALK. And so there's a lot of these nuances that I think, we have to, really have frank discussions about. And then, if I have a high PDL1 expressing patient who just hasn't had any other molecular testing done, is a current or past, smoker, I would talk to them about potentially starting single agent immunotherapy, or, if I'm really trying to get a response quickly, chemo plus immunotherapy, though, really trying to get the molecular data back as quickly as possible as well. We're getting a better understanding of the fact that some of these targeted drugs can interact with immunotherapy. So if you start a patient on immunotherapy and then you discover that the patient has an EGFR mutation or an ALK translocation, maybe you'll just switch them to the TKI at that point. Unfortunately, it's just not as easy because there is a drug-drug interaction and potential for increased toxicities when we have patients who've been on immunotherapy drugs and we're switching over to a TKI. So those are just some of the things that we all, I think we all have to consider when we're, talking to our patients. But there are some patients who just really don't have the luxury of time, and we do need to come up with a therapy right away. So I think it's really individualized.